So I think the first question I want to ask is really related to the fact that you guys were sort of an early adopter of looking at private third-party insurance legislation, and you may want to talk about what you've done with Medicaid as well. But the sort of pool model that you use as opposed to a fee-for-service model, why did you head in that direction? And is that something from your perspective from then and now, something that you would recommend to other providers that may be a better way of accessing private insurance and buy-in from the companies and or employers?
So the reason we chose to go in the pool model was because as we started doing this work with insurance companies, we couldn't figure out a way that we would get our independent contractors meeting the criteria to be in network with the insurance companies, and that started being sort of a barrier for us in moving forward. So the reason we're doing, we created an early intervention services trust is because that way the insurance companies contribute a certain amount each benefit plan year for each child, and then our early intervention program takes the responsibility to ensure that the providers meet our professional guidelines as far as what we require, and then it takes the onus off the insurance companies to be responsible for those providers' qualifications.
So in essence, you have been selected as the state program that's the gatekeeper for the services for private insurers as well.
For private insurers who are overseen by the Colorado Division of Regulatory Agencies. So this does not apply to insurance companies that are outside of Colorado's jurisdiction or that have high deductible plans or that are self-insured.
Okay. And could you speak to us about moving in this direction? And I know you started all of this a number of years ago and were successful in doing it. Who are the people beyond the program level that you had to convince that this was a really good idea to move forward?
Well, first we had to convince the insurance companies that this was a good idea, that they would fully fund early intervention services. We previously had legislation that funded, now I want to say, a certain level of visits per year. I think it was 20 for OTPT speech. And then that was the end of the benefit for those kids. So the major work was with our partner at regulatory, DORA, we call them, the Department of Regulatory Agencies. And then I think she was a really good partner, sits on our interagency coordinating council. And so she was really instrumental in helping us gather all of the leaders of the insurance companies. And we had to also, in some way, convince our local programs that this was a good idea, even though it wasn't a real heavy lift for them. They still, had their doubts about whether providers could provide services under an insurance plan that would meet the early intervention model, I guess I could say. And so we just had to be really clear with our message that it wouldn't look any different other than the way we build the funding.
And was there opposition, active opposition to moving in this direction?
No, I don't think so.
Mm-hmm. Was a lot of concern alleviated by the fact of going to a pool model versus a fee-for-service model, and I guess both for the state position or private providers in terms of having to do any type of billing themselves, or having the state do a pay and chase model or a central billing office?
Yeah, that's a great question, because I would say there would have been greater opposition had it felt like they would have had more onus on the providers to be billing. We'd obviously been trying to follow the funding hierarchy the whole time, but the benefits for each insurance plan were so different that it really was cumbersome for the providers. So the independent contractors, I'm sure, were very relieved that they didn't have to attempt to bill insurance any longer. I think the local programs were worried about any administrative burden on them.
Mm-hmm. And in terms of billing and coverage, it sounds like all of the therapeutic disciplines, there wasn't a question, and I guess I would ask that both for private insurance and Medicaid. What about what often states, some refer to it as developmental specialists, which one could read in many cases an early childhood, unappropriately credentialed for that position, early childhood educator? Were those covered within the pool?
Yes, in the Early Intervention Services Trust, all services are covered other than respite and assistive technology that would be covered under the insurance, and health services that would be covered under the insurance.
And I assume that was a major boon to the provider community as well, not knowing in your model how many or what percentage of individuals in the program are developmental therapists or specialists or early childhood educators. Usually, I always say developmental therapists simply because it's, education and private insurance doesn't mix very well.
Right, exactly. And another thing to mention is that the trust also covers service coordination. Okay,
great. And is that a standalone, or that's just built into the overall pool sum? It's not a rate per se. It is a rate, but it's a more global rate versus something that's driven by any individual service.
Right. It's all covered under the same pool. So the same amount of money is deposited for each child, and that covers direct services, service coordination. It's a flat rate per child per month, and then it also covers a management fee for the local early intervention program, and it also covers there's an administrative fee that covers the cost of administering the program at the state level.
And could you talk a little bit about how, from the general supervision perspective, that you sort of ensure within, and this is not to be a trick question at all, but how, if someone is being paid a pool rate and receives very little service in a given month, is the expectation that this all comes out in a total? So there may be a reason why a child's only receiving maybe one service, two services in a given month, but then the following month, maybe they've been on vacation, maybe the child's sick. Has that ever come up as an issue, both from the state level, or anyone raising any concerns about that? Or do you do reporting around that kind of information?
We don't monitor the trust any differently than we would monitor services across the board. Mm-hmm. And like any other program, we look at what's on the IFSP and is it being delivered or not delivered. And there isn't an issue if they go on vacation and then, so they might not have a service one month and then there'd be one the next month. It's been really challenging for the administrators of the trust when they reimburse the insurance company and we haven't expended the entire amount that was deposited for the child. And we've had to do a lot of education to them to explain it's individualized and they're depositing adequate money, we believe, that would cover a child for the year, but some might have more significant needs and it won't be enough, and some might have less services and we'll end up having to reimburse the insurance company.
And just if you could speak a little more to reimbursing the insurance companies, that does suggest that there is some type of annual, semi-annual reconciliation.
It's really complicated.
Okay.
And so each child that comes in who's covered under the trust has a benefit plan year versus the fiscal year. So the insurance company deposits the money, and even if the child is halfway through or 3/4 of the way through their benefit plan year, they deposit the whole amount. We draw down the money until the end of their benefit plan year. then we have to reconcile it with the insurance company, and then the insurance company has to then redeposit for the next year. Instead of rolling it over and just saying, here's your balance, you can
the balance of what was left, and then to get you back to whole. So instead there's money moving back and forth.
Yeah, and that's how it's written in the statute.
Okay. When you go back to sort of the planning relative to the implementation, was there specific data that I'm going to say that anyone wanted to see from the program? Did insurers want to see specific data from the program? Or as you have suggested, that you were doing this in concert with them, they felt you were essentially playing very straight up with them about what was going on data-wise, so that they knew that no, there wasn't an agenda beyond the fact of just to have more children get served through private insurance payment. Sorry, that was a long question. But.
No, that's fine. I understand. So, and of course, this was way back in 2007. So our data system now is much more robust. But what we had back then was whether the child was covered under insurance or not. And so we collected insurance, but that was not self-reported, but reported by the local program as they were, bringing the family into services. They would report on whether they had private insurance, Medicaid, or nothing. And so really what we had was the average cost per child. And then we had how many children were covered under insurance. And so we could sort of produce that so that the insurance companies could see this isn't, like it's not going to bankrupt them. It's relatively small amount for them. And probably they were looking at, and this is probably where Dora came in and helping them look at what is it costing them to provide the same service and to manage it, and then helping them understand that their coverage wasn't enough. And so, and then once the child's coverage under insurance was done, then they would flip over into early intervention funding, and they'd have to typically change providers, and the insurance companies did not provide services at home.
Okay. Speak, if you can, to individuals or people who insured individuals or employees from groups that self-insured. Did they participate, or have they sort of stayed out of the mix of potential payers? And a coupling of that question is, what's the broad sort of percentage, if you will, of self-insurance in Colorado as it relates to private insurance?
So we would treat, when the child's brought in, we would treat it the same way. We send over an insurance authorization form to the insurance company, and then they can, they'll respond back that, yes, this child's eligible under the trust, or they'll say, no, this child is under a self-insured company, or they have a high deductible plan. Right. And so we've seen it's been very flat this whole time as far as how many children are in the trust. And we believe it is because more and more companies have gone to, especially with the, now I can't remember the name of it, but Affordable Care Act, thank you. Yeah. Especially because of the Affordable Care Act, more and more insurance or companies went the self-insured route. Mm-hmm. And so I don't know that we would have the data, and that's a really good question.
What's happened, if there's been anything that you have had to address relative to ongoing maintenance costs of the system? Did you have to do changes in your data system? And if so, did you look to state funds in particular or federal funds to support that activity?
So the Early Intervention Services Trust has built-in administrative costs. So part of it's coming from the little piece that I told you out of the insurance companies every time we invoice a child. Yep. The second piece of it is all of the funding from the insurance companies comes in and sits in that trust, and it gains insurance. It gains interest. And so that interest is sitting in there to cover the administrative costs of the trust. And it's managed by one of our Department of Human Services accounting offices, separate than the building that we're in. Mm-hmm. And they created a manual sort of tracking system for how they did it through an Access database. And so it didn't link to our data system. And I think that was why it was pretty cumbersome. And we kept the invoicing data and shared it with them. And then they downloaded it into their database and did a bunch of steps to it to do all of their work. Recently, over the last couple of years, in 2015, we launched a Salesforce data system and revamped our entire early intervention data system. And then the trust we brought in is just finished getting brought in this year. And so now it's embedded in our data system. So now as the billing occurs, it'll happen real time and they'll be able to do all their work based on the data that we have. And as I said, it's really complicated.
Now, I have two questions, and I'll ask them both, but you can separate them out. What did you, in your initial stages, calculate that the revenue that would be generated by the change we're moving to, meaning private insurance coverage? And then jump forward, I guess, till present in like fiscal 19 or fiscal 20, how much revenue have you generated beyond what you thought you might in the first year or first couple of years? And conversely, I'm assuming you also are billing Medicaid, and is that part of the same system in the way that they reimburse, or is that a different reimbursement model with your state Medicaid program?
So, as I said, we didn't have a lot of robust data on insurance, and we wouldn't have known whether the child was covered by a Colorado, an insurance company under the Colorado jurisdiction or not. So we had calculated it based on how many kids in our data system were showing insurance and then the cost per child. And I'd have to look back, and I didn't, but I'd have to look back to see what data we actually produced. But I am going to say that the revenue was less than what we thought it would be, because then when you narrow it down to those kids that are in a Colorado plan that's not a high deductible or self-insured, then those were the kids that actually got enrolled and that we could access their insurance. And then, of course, there were some federal regulations, too, that were passed in the meantime that said that the family had the right to refuse use of their insurance and made it a little more complicated. And right. Very few families do. Right. But to this day, we've not seen a lot of increase.
So ballpark yield?
$4 million per year.
Mm-hmm. Yeah, pretty significant.
Yeah, I think it went from probably around 3 to 4, and 4 might be a little bit high, but that's approximately what it is.
Yeah. And what about your Medicaid program? Similar reimbursement model or totally different?
No, Medicaid, that's a completely different conversation.
Okay, but you do generate revenue from the state Medicaid program.
Significant.
Yeah. Okay. Ballpark on that one?
Probably 10 million.
Okay, great. But do you have other questions that you would like to answer that I haven't asked? So if you have something you want me to ask you, just tell me what it is, and then I would appreciate you to answer it as well.
No, I guess I would just have a final comment about, I think we were pretty cutting edge to do this in early intervention insurance trust, and we've learned a lot. And if people are considering that, it works very well, but I know I've said a couple of times, it's very complicated to administer. And that's because the way it was written in statute makes it that way.
Mm-hmm.
So I would say, think about, we didn't have any models to look at to say, oh, maybe it should be written this way. So I think thinking about the logistics of fiscal years and benefit plan years and how you word reimbursing the insurance would simplify things a lot. And I don't think we've thought about going back to the legislature and asking, kind of opening up statute and trying to change it, because it's a pretty big coordinated system of payment statute. Mm-hmm. But and I think we haven't wanted to rock the boat, because there is an increase. So it went from about 4,000 something per year that the insurance companies would contribute. It's now up to over 7,000. So it's increased every year based on some formula that they use.
Great. Well, very good.